Noting that it is 7:05 p.m. on September 22nd, 2021, I will call the special virtual Board of Health meeting to order. And we have a quorum of the Board of Health. So I'm Chair Daryl Beardsley. We have Matt Beavers, Lisa Camp, Matt Vitale, and is Rebecca on? I didn't see her in the list just yet.
I'll check.
Yeah, I don't think so.
Okay, and then also note that we are having a joint meeting with the Dover Board of Health for the purpose of discussing this topic of mandating COVID-19 vaccinations for faculty and staff at DS. And so I've opened our meeting. Would you like to open your Dover meeting as well?
Dover Board of Health is opening this special meeting on September 22nd evening. I, Stephen Kruskal, are present.
And I, Kay Peterson, am present.
Okay, and if we have any votes, we'll do roll call votes since it's a virtual meeting. And also, I would like to, we've posted that this is the topic for discussion. There are certainly tangential topics that might relate to this and COVID-19 mitigation strategies within the school system, but I would like to keep it to this topic because this is what was posted. And if there are other topics that people were thinking we might be discussing tonight, we can have another meeting at some point to address those. But I think it would be a disservice to people who came expecting just this one issue, which is all that we were planning.
I also think, it's a posted agenda item. And so for a posted meeting, this is what the agenda is, but I would certainly encourage folks who are interested in attending to come to the regularly scheduled Board of Health meetings for either town, depending on where you're a resident.
Mm-hmm.
Daryl, is it okay if I kind of introduce the discussion? And
yes, I was just about to ask you to do that.
Perfect. So I think we're going to open with a period of public comment. We would ask that you focus on the posted topic in terms of faculty and staff vaccination for DS. I would encourage folks to limit their time to 2 minutes and to not rehash points that have already been made or raised. I think our experience in some previous meetings has included the dissemination of information that may be factually incorrect or misleading. Our intent is to address that in the follow-up section. We're not intending to sort of address that on an ad hoc basis with each commenter, but we'll address any pertinent sections in the discussion. It doesn't mean that it's an endorsement of those facts, but rather that the purpose of the initial period is to allow public comment. I don't know if folks have any other comment. I think we'll then transition into discussion among the board, and we'll go from there. I don't know if any other board members have comment for the public comment period.
If people could identify themselves and their address, that would also be helpful because I'm supposed to be tracking participation.
And I think the other piece is, while we typically focus comment on those of Dover and Sherborn residents, given the topic, we'd also welcome teachers, faculty, and other DS staff to self-identify, but you're also welcome to make comment as well.
I will try to keep an eye on them and give people a reminder if they're getting close.
And so if you'd like to make a comment, please raise your hand, and we'll kind of go through in that order.
Guess I'd also like to mention that there will be an opportunity for commenting again later too, in case people want to ask questions about whatever is discussed.
Okay, I don't see any hands raised. Does anybody else see a hand raised?
I do not.
All right, let's go ahead and proceed.
Okay, so it's okay. Are you going to be kicking this off? Since I'll just mention that from the boards of health, there are a number of people who work with the school administration on the health and hygiene work group there. So that would be Kay, Matt, and Matt. So
Matt
I think it's
Beavers.
appropriate that you, yes, Matt Beavers and
Sure.
Karen.
Yeah, I'm happy to speak speak a little bit to that. You know, I think as we think about whether we want to do this, I think there are a couple considerations to make. I think the three chief that come to my mind are sort of one, is the vaccine effective? And I think that's pretty well established at this point. So I don't want to spend a lot of time on that. I think we know pretty well that this is probably the best way to prevent COVID-19 and all the implications of that. I think second is the question of how well are we doing so far? And my understanding from the district is that we have a very high rate of vaccination among our faculty and staff. I think greater than 95% is the number I heard, but it's not everyone. And I think that, you know, that in and of itself is probably not a reason not to take action. I think we want to think about sort of doing what we think the right thing is and be a little forward looking for potential new hires or as things change. And so then I think the last question that often comes up is, are these vaccines safe? And I think the initial trials were very encouraging in that regard, but I think over time we've seen additional side effects come out. And I think whenever we think about whether we're going to require something, we want to make sure that the benefits outweigh the risk. And so I wanted to spend a minute just because there was I think some of the best data we've seen on safety that recently came out. And so I think I'm allowed to share my screen, right, Daryl?
Yes. Yes.
I just want to show this article, just a couple slides from this article that was in the New England Journal just last week, because I think this answers some of the quite outstanding questions we've had. And I apologize. I'm going to be looking away from you because I got to look at the other monitor. So hopefully you're seeing a flow chart here. And so this is a really, really well done study looking at safety. And so I think, you know, the gold standard for trials when we think about studying something like this is the randomized controlled trial, right? And those are the studies that initially got us approval of the vaccine. I think part of the issue there is that we don't have larger numbers from those trials, and we couldn't sort of keep them going for forever because once we knew they were effective, it's not ethical to sort of keep people from getting vaccinated and try to understand what the differences are in safety events. And so this recent trial, I think, did the best possible thing we can short of that to show safety. And so what they did is this is a study based in Israel where they've got sort of a large national health system that follows just about everybody. And so what they did is they looked at the sort of 3.5 million people in that health system, pulled out individuals who'd been vaccinated and then matched them on a number of characteristics, sort of background medical history and demographics and socioeconomic status, to try to simulate a randomized trial. And so they looked at all these individuals. They looked at people that hadn't had any contact with healthcare recently to suggest that they were sort of relatively healthy coming into this. They then looked at each individual that got vaccinated, and then they matched that with a non-vaccinated individual and followed them for 42 days. And so the idea here is the closest we can come to a randomized trial to really look at what things happen after vaccination that don't happen in people that aren't vaccinated. And so this is sort of the flow sheet. You can see what they did and their various exclusion criteria. But in the end, they pulled out just shy of 900,000 people who were vaccinated and matched them with just shy of 900,000 unvaccinated people to really get a sense of what things are happening after the vaccine that wouldn't otherwise happen. They then did the same thing for COVID. So they wanted to find people who were infected with COVID, match them with individuals who were not, but yet had not been vaccinated, neither of whom had been vaccinated, and then follow them over time until either the control person got COVID or one of them got vaccinated to see the incidence of these side effects for COVID. And so in the end, what this is trying to do is say, what are the side effects from the vaccine? What happens to people who got the vaccine that doesn't happen to people that didn't? And then what is the incidence of those same things in people that got COVID? Does that make sense? So we really want to get a sense of what are the potential downsides of vaccination and how do those downsides compare to what COVID can do to you? And so this slide shows the comparison. And so what these numbers are is if you look at 100,000 people who got the vaccine in blue here compared to 100,000 that didn't, what's the difference in the number of people with each of these side effects? And then in orange, if you look at 100,000 people who got COVID versus 100,000 people that didn't, but also weren't vaccinated, what's the difference in the risk of these side effects? And so what you find is that any negative number suggests that it was protective. So it suggests fewer people had the side effect. Any positive says more people did. And so if we go through and they looked at the long list of side effects, all of which have been reported in public databases, and try to get a sense of everything. And for example, myocarditis is something that we've heard a lot about as being one of the major risks of the vaccine. And what you see here is that for every 100,000 people vaccinated, there were 3 extra cases of myocarditis. However, for every 100,000 people who got COVID, there were 11 extra cases of myocarditis, right? So, and while they're different groups, and so we technically can't compare head to head, it suggests that there's not an excess risk there. I think where we do see excess risk is lymphadenopathy, right? So swelling in lymph nodes happen more often after the vaccine than in people who were unvaccinated. And it wasn't a major feature of COVID. And then the other major one where there was a difference was a zoster infection, so shingles, effectively. So reactivation of the immune system in people who got the vaccine versus those that didn't. And still these numbers are small, 16 per 100,000 or 78 per 100,000. And so I think we're hitting a point in which we've got really high quality data, probably the highest quality data we're going to have on the safety of these vaccines. And so for me, I think we've hit the point in which we can feel really confident about this. Felt really confident after the trial, and I'm more so now. We now have FDA approval in people over age 16, and we now have more and more safety data building up that really shows that side effects are rare. They tend to be mild, the ones that are significant, and that oftentimes the effects of COVID on these same side effects are worse. Now, this isn't to say that there aren't rare cases, right? Like people can anaphylax. Like I'm not going to say it's not impossible, but I think overall, as we're balancing the benefit of these vaccines against the risk of these vaccines, there's really no question in my mind anymore that they're safe and they're effective, and the benefit outweighs the risk. Any questions from the board about that data?
So really helpful information, Matt. Thank you.
Matt, the Israeli study was in adults, or did it include adolescents?
It was in adults, 16 and over. Yep. So the same population that's currently FDA approved. So we don't. That's an excellent point. I think we're talking today about faculty and staff, and that's the group for whom we have the best safety data, who we have FDA approval now. Right now FDA approval in the U.S. only goes down to age 16, and I think we're all waiting for additional trial data and safety data in younger age people.
And Matt, when you say excess risk, I just want to confirm that means beyond what would have been expected in the population absent either a vaccination or COVID.
Right. So what I'm showing here are absolute risk differences. And so it's in each case comparing the vaccinated to the unvaccinated or the COVID positive to the COVID negative. And so it is above what you would have seen. There's another slide here that I didn't show. But so this is showing now risk ratios. So one is the unity line here, suggesting that the ratio of risk is the same in the either vaccinated, unvaccinated, or COVID positive, COVID negative. And it's showing for those same examples. So let me find, so lymphadenopathy, the risk ratio is just shy of 3. So just slightly more, threefold more likely in those with a vaccine than those without. But then this is showing what those absolute numbers look like. To say that threefold higher means 78 extra in this case.
Just one slight question. I think you're saying this is 16 and up, right, Matt?
Yeah, it might be 18 and up.
But in this country, it's 12 and up, right? Now that
FDA approval hasn't gone down to 12. The vaccines, 12 to 16 still under an EUA.
Oh, okay.
Yeah. So this study was 16 years and older by the inclusion criteria, which matches the currently FDA approved vaccine. Other questions?
Oh, the only other thing I was going to ask is this primarily, and maybe you said this and I just missed it, Pfizer, because isn't that the predominant vaccine?
Yeah. So I think Israel's overwhelming majority of vaccine, if not all, was Pfizer. So most, if not all, data you see come out of Israel, whether it's effectiveness, Delta, booster shots, or this, is all in the Pfizer subset.
And for the adverse events, that the risk ratio goes up a bit from vaccination. Are those treatable issues, or
So
too hard to
lymphadenopathy,
say in the general?
lymphadenopathy is basically just like a swollen gland. And so I suspect, but have not reviewed the appendix of the Israeli paper for, this is what lymphadenopathy is. But for example, if you got the vaccine and then you got a swollen gland in your armpit, I suspect that would meet the criteria for lymphadenopathy and would typically be self-limited. I think shingles is treatable but miserable. So I think you'd really say, boy, I'd really rather not get shingles. I think the flip side is, having taken care of a lot of COVID, I think lots of people would say I would rather have shingles than COVID. And so I think that the point Matt made earlier is all of this is already taken for granted a substantial difference in both severe COVID, meaning hospitalization, oxygen requirement, or death. And we've sort of taken that for granted. And that benefit is already sort of not part of what we're presenting here. It's really to say, if we then say what else came along with it and ignore that substantial survival benefit, then we see these side effects come out. So I think that you can say, boy, if we vaccinate 1 million people, we're probably going to see some people who have shingles that may have been triggered by the act of getting vaccine. That number is small, and it's much, much smaller than the number of people who would receive a benefit and in terms of protection from COVID.
Absolutely. And having had shingles and taken care of COVID, I will tell you, I will pick shingles every time.
And it's a very modest relative risk increase.
Yeah.
But again, I think if we want to, for me, as I read the data, I think it's a very modest increase. I think it's one that when you look at the data, you say it's there. And so as we think about choices, it's one of the things we should think about, because I do think it's a piece of the information. I think to Matt's point, for me, it doesn't change the calculus of benefit. So if there are no other kind of questions or comments on the data piece, I'd love to make a comment, but just want to make sure I'm not cutting off anybody on the Dover side.
No, I'm all set.
Okay. So for me, I think, Matt, you did an awesome job kind of sharing that. I do think that's both timely and helpful information. I think for me, it kind of comes down to the question of what's our most important thing? And so we kind of, whenever we make choices about risks and benefits or how we proceed, I think we have to stay anchored in saying, what's the thing that is the most important, which is going to be what drives the decision. I think what we heard from families, from staff, from our whole school community last year was being in school safely is our most important thing. And so I think any decision we make needs to be anchored in, does this pursue that goal? Is this consistent with that being our most important thing? And so for me, the other thing that I think came very much out of previous discussions was hope for normalcy, and to be able to safely pursue normalcy as the kind of the course of COVID evolves. And as we as society get access to vaccines for younger kids and other pieces. And so I think from my standpoint, having expectation of vaccination makes sense, because I think that safety data supports it. And I think as we look and see transmission, there was another great paper that came out of Marin County from the end of last school year that was, again, it's one single case series, so it's a small sample, but was essentially a classroom teacher, unvaccinated, doing something as simple and natural as taking their mask off to read to the classroom. Unfortunately, this was, I think they had 21 out of 23 teachers in their school vaccinated, if I recall correctly. And this was one of the 2 that wasn't. They were unmasked and then had half of the classroom acquire COVID with multiple secondary strains, secondary infections. The part that was particularly helpful about that paper is they did the genetic sequencing, so they could say and really link the cases where the predominant strain was related to that index case with the teacher, who again did things that we want Dover Sherborn teachers to be able to do, is to sort of act naturally in the classroom when circumstances allow. I think what that taught us is that with Delta and without vaccinated children, that doesn't include time unmasked, but I think it also shows how in a school community with a very high rate of vaccination, small pockets of not vaccination can have substantial school disruptions. And if we're saying as a community, our most important goal is to be together in school, have in-person school and all the benefits that brings, I think it highlights the necessity for being as close to 100% as is feasible. And that's it for me. With that, I'll gracefully go.
Okay, so I'll just mention that I'd like to see the spread kept down. And I do believe that's essential to keeping the schools operating as much as possible. And that's important to the kids. Are there any teachers, staff from the Dover Sherborn school system who would like to speak? And a couple other questions for the health and hygiene group. Has DESE made any comments about this topic yet?
Not that I'm aware of. I think they've essentially said that it reverts to the individual communities, I think in part related to the presence. And again, I'm out of my sort of lane of expertise, but that it kind of reverts to individual districts and the bargaining units contained therein. And so we're deferential to local governance. And I see Christine Atkinson with a hand up.
Hi, thank you. I actually am a teacher at Chickering. I just have a quick question, and maybe you can answer, maybe you can't. This is a very big surprise to me, and I would expect most of my colleagues, having no idea this was even being discussed, found out about it kind of last minute. Is there a reason that we're looking at this? I mean, I get that everybody wants to be protected and safe and healthy and all that, but is there something that's happened either within the schools or the community that's made the feeling that we need a mandate? And I know we have a very high population that's already vaccinated. So I'm just kind of wondering what's kind of behind this conversation.
I'm happy to tackle that unless others would like to. Is that all right with you, Matt and Kay?
Go ahead.
Yeah, so I think that there's no specific one-off that says today's the day to talk about. I can talk a little bit about this as this kind of background in terms of the different points. So we had a meeting several months ago before the school year started where we sort of had considered, is there a role for vaccine mandate at that point? At that point, we didn't yet have FDA approval. We didn't have the safety data that we've now seen. And we also, when we looked at it, said there's a lot of other parts and we're not clear on what we'll get state guidance on or not. I think our experience with masks is a good example where we had an extensive discussion, received a great deal of kind of public comment as well as individual outreach after the meeting. And then the next day or 2 days later, the state said, oh yeah, actually we're gonna do a mask mandate. And so I think our hope was that ultimately the state would provide some overarching governance rather than having this revert to individual districts. And that guidance wasn't forthcoming from the state. So it's a little bit paused to say, if they're gonna have guidance, we don't wanna kind of reinvent the wheel because there's plenty of stuff for people to think about. I think that the other pieces contributing to it, and this is just for me, like I can't speak for everybody. I think it's also looking at how Delta has evolved. If you sort of asked me in June, how worried am I about the fall? I would have been much less worried than I am right now. And so it feels like there's some urgency to try to think about how do we do it. And while I know that there are lots of people who provided their feedback that didn't agree with my feelings on the mask mandate, I think one of the things that came through that does resonate is really thinking really hard about everything we're doing at school that's not normal isn't free. It matters to our kids, it matters to our teachers, it matters to their families, and trying to think as much as possible, how can we thread the needle so that we can safely have school? So are you okay if I do like a somewhat totally anecdotal personal aside? So I grew up in Anchorage, Alaska, and the hospital in which I was born is now one of the unfortunate subsets that are doing crisis resource management. So it means that patients can't get on a ventilator, patients are dying because they can't get dialysis. And you look at that and you look at how fortunate we are here and you say, what's different about these? And for me, it's really the choices we're making as a community, whether that choice is vaccination, spacing, distancing, or other priorities. And so for me, it's really trying to think about how do we get as much normal as we can safely give our kids while giving as much safety as we can give our teachers and staff and our school community at large. And how do we sequence that over time? So it's not that at some point we get to like, here are the 47 things that we have to do. And this felt like a natural time, particularly with pretty robust uptake, to say, this feels like an important thing to communicate. think the last piece is that we also get clear guidance from the federal government in terms of what are the general things playing out, where we again see messaging around large employers in OSHA, which doesn't apply here. That's not the relevant regulatory authority. But I think that's the other thing that also says, if that's what we're saying for chicken plant, do we really want to have it different here? And how do we balance that? And so I think for me, at least, that's what I'm trying to think through. Does that make sense?
Yes, yeah, it totally. And to be honest, I think, or I know for a fact, obviously you think about this all day long and think about it not only for your own work, but then think about it in terms of the community. So I thank you for that. And for us coming back, being vaccinated or not, depending upon I am, I feel much more comfortable. So there's a piece of that I'm grateful for. So I guess it hasn't been top of mind to be looking at a mandate. To me, a mandate seems like a pretty big deal. I'm not saying I'm for or against it, won't get into that. But I was just taken back. That's all it was. It was kind of like, has something happened that we weren't aware of, or is there something different we need to do? Did the community feel like the schools weren't safe and so we needed to take an extra step? And so that was more just, I figured rather than let it stew and bother me,
Totally.
I would ask.
Thank you for doing so.
Okay. So yes, it made sense. Thank you very much.
I'll mention that I've heard people commenting in town that we live in such a bubble and we're so fortunate, but we are actually seeing cases coming in similar to what we did last summer when we were concerned and earlier in this year. So we're not immune from it, I guess, is the other piece of it. So we're getting,
I mean, hopefully we're vaccinated.
Ellen, would you
for a little
say
bit.
something like 0 to 4 cases a day, with I think 1 to 2 the most common in Sherborn alone.
And I think we've also seen, I think one of the patterns, and I'm going to kind of make this comment globally, not specific to Sherborn, just because I think the data gets too granular in a town as small as ours. But I think that some of the patterns you do see is the proportion of infections made up of of people young enough to not have vaccine access has definitely increased. So if we look at the kids under 12 proportion or the kids under 18 proportion as a percentage of total infections, that's a much higher percentage than it was before because they're a bigger part of the universe of people who are more likely to get it. I would say we definitely see the cases where a case comes in and then we see multiple members within a household kind of flip positive later, whether that's at the state level or locally. And so it's a little bit how to balance those risks as well. Even when we get our kids vaccinated, a lot of our kids are still going to have younger siblings who will be below the age of 5. And I think thankfully the disease has not been nearly as important in grandkids as in grandparents, but trying to balance those risks.
And I would add that this is related to the Delta variant, that we're seeing not as many as we would have anticipated without vaccination, but in vaccinated people, we're seeing some breakthrough cases. Certainly the vaccine protects people a lot from infection, but given how infectious Delta is and that we are seeing some breakthrough cases, we can't really say, well, we have 95% uptake of the vaccine, we're therefore really safe. We need to, as Matt was saying earlier, we need to add as many layers as we can feasibly to try to protect even vaccinated people more than we're protecting them now. If right now our case rate were next to 0 in the schools and in our towns, I think we wouldn't be having this conversation, but we're seeing a substantial number of cases, and it's substantially more than we were seeing in early July when it was practically 0. It was 0 for a while. And the other, I think this goes without saying, but the number is continuing to rise. It's not as if we've even reached a plateau yet in our communities or in Massachusetts.
But I think the case study that Matt Vitale brought up, where even just a couple unvaccinated people, with children, especially those who are 12 and under who are not yet eligible for vaccines, it can turn into almost a mini super spreader event. And then those people also have siblings who might be older and there could be breakthrough infections. And it's just, I think, a cycle that we want to nip in the bud to the extent feasible. So I think it makes a lot of sense.
And I think for me, it comes back to what Matt led with, right? Like, I think the most important thing we can do for our kids is to let them be safely in school. And right now in our communities, the kids, particularly the younger kids, are the biggest pool of people who don't even have access to vaccination. And so I feel like anything we can do to ensure that as many people as those kids interact with as possible are vaccinated and hopefully therefore at lower risk for spreading to those kids who don't have that chance for protection for themselves is important. And I think it's important for the kids in the school, but it's also important for our community, right? I think it's the pocket where we're most vulnerable. And so it's the part of our community that needs the most protection.
Out of curiosity, I'm assuming a mandate would have some caveats about whether people for medical reasons, it wouldn't be appropriate for them to get a vaccination. So that would be one. And then do we have any sense of the people who are unvaccinated, how many of them have that circumstance?
So I don't think we know the specific information. I think for me, the way I'm thinking about it is I think it's our job, if we so decide, to kind of make the requirement, and then it's up to the district and the school committees to translate that into policy and protocols, whether that's incorporated with the bargaining units or the other pieces. So I think for me, what I don't want to get too much into the lane of others. And I think for me, it's kind of the on-off. I do think there are many instances where there are permissible exemptions. And then I think it's important to also have mitigation strategies to say the presence of that mitigating factor. I'd want to see us supplement with testing or screening or other things. Because again, like, it matters so much to have our kids there. And I think that the thing that will really disrupt that is if we get spread within schools or, that sort of wider spread pattern, which I think we're still vulnerable to. But again, I would say I would imagine that there'd be exemptions that could be appropriate, but would favor having, or would recommend having testing be a component of that.
I guess one other piece of this is I wouldn't like to see people thinking that if the vaccination rate goes up more, that would mean that masks wouldn't be necessary. Again, as Kay mentioned, and others have mentioned, you can be vaccinated and still be infected and then spread the virus. So the dynamics may be somewhat different, but it's still possible.
So what I would say, Dale, is I think what I hope for and dream of, but I don't know that we'll get to one spot where we can say, like, my goal is absolutely to end up in a place where we can have kids in school safely together, so that I have to shave more regularly, so that people are unmasked, and so that's a safe way to do it. I don't know that us getting to some threshold 2 weeks from now is going to be the thing that gets there, but I think we want to be clear that, like, masks are a really important safety strategy right now, and we should do our absolute damnedest to figure out a way that we can get past that as a community over time with high uptake. And that's going to depend on how the virus evolves. That's going to depend on what happens, because ultimately, my most important thing isn't to see my chin, it's that my kids are socializing with kids in their class and that we're in school. And so I hope we can get to a place where things like aggressive vaccination make that feasible. I don't think we're going to get to a cut point where we're like, we went to 97% or we went to 98%. And now that one measure did everything, because I think COVID has taught us we need to stay balanced and thoughtful, but we can safely do things right now that we couldn't do last year before vaccination. That is awesome, and that matters, and I want to see us keep working to that. And Steve, I see your hand up.
Should we decide upon mandatory vaccination, I would like to see attached to it, for those who are unvaccinated for any reason, mandatory testing that should come from us. And I cite as an example the town of Brookline, which passed something similar with testing 3 times a week to really cover the waterfront as much as it can regarding carriage.
And I think Newton passed a similar testing requirement. At least is what I saw in the lay press. I didn't see the primary meeting.
And do we have a means to access testing for teachers and staff? Because I know it's hard to get some of the rapid personal tests.
I think some of that, like, I would put it on us to say this is what we'd like to see, and kind of let the district work on the implementation pieces of that.
I think, Daryl, for instance, you're right that it might be challenging, though not impossible right now, but I suspect it will change over time and get easier, because I think there's a temporary shortage of the of the Abbott Buy Next Now kits. But there are lots of ways to think about the logistical problems of the testing. I think our
Okay.
goal should be to decide what we think we want to see and vote on that.
Are there any other comments from members of the boards or from teachers or staff?
No, but I do see someone with a hand up.
Yep.
so-
Yeah. No, I just want to make sure we get that.
Yeah.
Ms. Dye?
Yes, hello. So I took notes during your presentation, so my comments are gonna probably follow those notes. The first thing I wanted to mention is that in the study that you referenced, you did mention an increase in myocarditis being more prevalent. And even if it's only one case, the heart does not regenerate. So if even one of our teachers were to get vaccinated because we mandated it and they got myocarditis, basically we have damaged their heart for the rest of their lives. And I personally would not want to be responsible for that. So that's my first comment. Number two, if we're already at the 95 percentile vaccination rate, which is really, really high, which, you know, I'm sure you guys are quite proud of. I would say that the colleges who are very much mandating and, you know, really pushing the vaccination, they were very satisfied with hitting a 90 to 95% vaccination rate. So when they hit 95%, they, you know, they were happy, and they basically just said that the kids that didn't get vaccinated, whether they had a religious exemption or a medical exemption, could get tested on a weekly basis. So that seems to be working. So I would highly recommend that in Dover Sherborn as an alternative, as other people have mentioned. Number three, if a staff member at this point has not been vaccinated yet, they either have an allergy or a religious belief or a medical exemption or medical reasons. And I personally think we should respect those beliefs, especially because our vaccination rate is so high. Number four, it could be because of childbearing years. I know that there are studies that in the first two trimesters of pregnancy, 83% of women miscarry their children, their babies, their unborn children. And I know you're going to say, no, it's only 16%, but that's only when you add in the third trimester. So if you only count the first and second trimester of pregnant women who took the shot, 83% of them have miscarried. So if I were a woman in the school of childbearing years, I would not want to have to take that shot because I would be afraid that I wouldn't be able to carry a child. Number five, if we mandate this and they fall ill, whether they get myocarditis or they get some other, you know, Bell's palsy or pericarditis or any other medical issues, they can't sue Pfizer or Moderna or J&J, but they might be able to sue Dover Sherborn. And I don't think our towns want to pay those lawsuits if it were to happen. Number six, as far as I've been able to see in the studies that I've seen, Israel has the highest rate of vaccination, but it also has the highest rate of cases right now. That's at least the studies that I've seen. So to me, that would correlate that the more highly vaccinated you are, the more highly number of cases you're going to have. And that's because the virus is leaking. I'm sorry, the vaccines are leaking and they're spreading it. We've all acknowledged here that people who are vaccinated can get COVID, can spread COVID, and can even die of COVID. So vaccinating our last, 5% of teachers, I'm not sure that's going to save the children. And number 9, if DESE has not even addressed this, I don't know why we are even going there yet. I don't know why we're doing that. I know that the state troopers in Massachusetts union just sued the state of Massachusetts for the mandate. I don't know that we want the teachers union to sue Dover Sherborn or DESE or whoever. So I don't know why we're doing that when we have such a high vaccination rate. Lastly,
Kathy,
yeah,
your time.
yeah. I have
You're
one
at
last-
time,
my
and
la-
if you want us
I have
to.
One last comment, my one last comment is that if we lose even one teacher because they leave, because they can't get a medical exemption or a religious exemption, we're gonna lose a very valuable person in our school system, and we can't replace them because there's a huge shortage right now. So those are my comments.
Thanks, Kathy. Matt, is it okay if I kind of take a first response?
Sure, and I may chime in.
Perfect. In terms of the information shared by Kathy, there are a number of pieces of either misinformation, inaccuracy, misreporting, or mischaracterization. So I'll try to address the ones that stood out in the 9-point session. I may miss some and certainly would invite Matt Kay or Steve to weigh in. So the miscarriage data is not correct, just flat out not true in terms of the organizations of obstetricians and gynecologists. The overwhelming support is that the morbidity and mortality of COVID substantially outweighs the risks associated with vaccination, and they recommend that people get vaccinated. In terms of the characterization of myocarditis, in terms of, I haven't seen the Israeli data in terms of how they characterize it, but in terms of the pediatric data where this has been more clearly expressed, the vast majority were self-limited and resolving without a requirement for hospitalization and without long-term harm. So that's an inaccurate mischaracterization. I think in the state of Massachusetts, DESE has weighed in on it and has said it reverted to local governance, which we are a member of and so are acting. In terms of whether or not we could be sued or liable, it's certainly a possibility. I think that it doesn't weigh in on the question of what's safe and prudent to do. And I think in this case, the state, and again, the governance of the teachers unions or how those connects, but the MTA has certainly been supportive of vaccine requirements. And so my level of worry there is low. And I'm trying to remember in terms of the other medical inaccuracies. Matt, maybe you can jump in.
I think that covers most of it. I think to say myocarditis always causes permanent damage is a gross misstatement as well. I think the one other point that was made, and I think Kathy even used the word correlation, is to try to correlate vaccine rates with COVID incidents. I think we're seeing COVID incidents go up everywhere. I mean, and that has nothing to do with vaccine rates. The vaccine does not make someone spread COVID. It simply, you don't get out. There's no active virus here. The simple answer here is that correlation is not causation. I mean, this is sort of statistics 101. This is like understanding sort of medical science, public health 101. Like lots of things correlate, but that's not causative. And I think we've seen a lot of that in publicity around this idea of Israel having more cases, but it by no means was caused by vaccination, and there's no way you can show that. So I think to suggest that link is just patently false.
One thing I would add about myocarditis, and that is that Matt Beavers, as you showed earlier in your first slide, the risk of myocarditis is greater among people who are infected with COVID than it is in people who've received the vaccine.
I would disagree with that.
So it's not a question of agreeing or not agreeing. It is what the data shows. Kathy, I'm speaking as a member of the board right now. Thank you. The data clearly shows that. It's shown that in multiple studies. We now have very high quality studies showing that. And so it's not a question of opinion. It's a question of this is proven as well as we're going to prove it now.
I hope you don't get.
And the relative risk of long-term COVID and repercussions from teachers or students getting COVID is so much higher than the relative risk of these very low incident side effects from the vaccine. So I think it's just, if you do a risk benefit analysis, it strongly weighs in favor of getting vaccinated versus not.
And so if we sort of have had the period of community comment, we've had teacher and staff comment. Is there further discussion before the board, or do we want to move towards a motion?
I thought I saw one other person with their hand up, but now I don't.
Right, there was somebody else.
If they're down, they'll be.
Yeah, I don't see it now.
Okay. So it sounds like, at least I'm not sure if I don't know the verbiage right, but it sounds like the punchlines are, from what I've heard, there is support for a vaccine mandate, that would then be a requirement from the joint boards of health that would then be implemented into policy and protocol via the district and the school committees as appropriate. it sounds like there is a feeling that for those who are exempt, whether that's medical, religious exemptions, that we would then require a testing strategy to mitigate the risk of transmission. Did that sound like the key points to folks, and am I missing any?
Aren't we making a recommendation to the school committee? So we're not, in fact, making the requirement, they would be making the requirement?
I think we're making the requirement and then they're turning it into the policy and protocol. So I think we could say the vaccine's required, but the nature of their adjudication process for medical exemption, for example, would revert to the district and policies therein, or if there's components that enter in with the bargaining units.
Okay.
And just as in terms of process, is this the type of thing that would normally be discussed with the staff at the schools before proceeding, or is that part of the policy development that comes after our requirement if we choose to vote that?
So I think that we would sort of have an output here. It would then, I think, ultimately also be discussed and reported out at school committees is my impression. And that then in terms of policy and protocol communication, that would be the district's usual channels. But again, sort of out of my lane in that regard.
Mm-hmm. Okay, I guess I asked partly, I don't want to complicate whatever their next steps may be by making it a requirement. That's
I think
just my question.
I think it's been clear that as this is a matter of public health, we can require it, but I think we could do it in a way that gives them room for implementation. Mm-hmm. And so I think to Steve's point, I think I would love to see thrice weekly testing, but there may be logistical barriers there. And so I may be more in favor of a motion that, you know, if people have medical or religious exemptions, that they must be enrolled in frequent testing, while still allowing them some room to implement. As much as, you know, I mean, I'd love everyday testing if I could get it, but I don't know that that's realistic. And so I think we could probably do this in a way where it's clear that it's required, but it gives them room to figure out the exact implementation in a way that works for them.
And again, just like everything else during this period, that can be subject to change as conditions change or test availability changes or what have you. So I would prefer to give the flexibility. I like that.
And I think my other suggestion is, I think right now, you know, I would recommend, again, like what I would say is, I think right now we'd say vaccination. I think getting into details of, you know, this is 2 shots versus other boosters in the future versus what have you. I think for the purposes of this, you know, kind of keeping the requirement clear, but also not overly constrained in case some data changes 3 months from now, that we don't then say this is the requirement of the board that's no longer pertinent.
And I imagine that the school committees will dictate the timing of the mandate requirement, correct?
I think so. You know, again, for, you know, my piece feels like our goal is to regulate as much as necessary and as little as possible. And so it's to really give clear guidance about this is the thing that's required. And then as much as is feasible, I think that if we said, people said, you know, this has to be done by June 1st, 2022, I'm not sure that would kind of pass muster, but I also think it's a really unlikely outcome. So I think I would favor saying this is the requirement, and then, you know, sort of have faith in the rest of the system to make sure it's sort of pragmatic and prudent.
Are we, is our recommendation tonight, are we staying focused on the vaccine issue, or are we including masking and testing requirements? Because I feel like those are extremely important and those should be included in our recommendation.
So I think we previously voted on masking. Mm-hmm. And so that's currently in effect. And so I think tonight's discussion is limited to required vaccination for staff. I think it would be reasonable to include in there that if staff have an exemption, that they be required to undergo testing. But I think that's probably about as, I think, because that's directly related to not being vaccinated, I think that fits, but I think I wouldn't go further than that tonight. Partly because we didn't sort of post that we were discussing those other issues tonight.
Right, okay, and the exemption, we will include the list of reasons for exemption, medical, religious, whatever the standard.
I would sort of let, yeah, I mean, I think I would leave to the school the kind of specific protocols and policies related to this is how the exemption gets adjudicated. You know, this is the list, this is the process, you know, this is the materials that need to be submitted. I think all that is most appropriate to go through those policies and protocols for the district, because I don't think that level of granularity is in our lane. And it's just not the place where we're bringing useful expertise, whereas I think the district has a lot of expertise in those regards.
And I would also be in favor, I know this isn't specifically on our, of including increased testing, regardless of vaccination status, because of the, you know, the ability to transmit virus with a vaccination.
Right. I mean, I think we have pooled testing ongoing in the schools, and I think we can discuss that at a later date, but I think we shouldn't include that in tonight's motion just because that was not sort of on our agenda for discussion. And I think, you know, I'm happy. I think at our regular meeting, we have a COVID-19 update every week, and we can sort of discuss where we're at with enrollment in the pool testing, which has been encouraging. I don't have numbers in front of me, but it's been encouraging thus far.
And then going back to the exemptions concept, I'd also like to leave that to the school, because someone may have a reason that we wouldn't be able to think of and articulate this evening. So,
Steve?
I would expect that the exemptions that the school suggests be subject to review by our combined board.
I think that's reasonable.
Yeah. So do we want to take a shot at a motion?
As long as you're the one taking the shot.
Okay. So give me a couple chances, and then maybe I'll share my screen and write it down just so we can all take a look at it written.
No pun intended, right, Matt?
What's that?
No pun intended.
Yeah. Taking the shot. Sorry. Yeah, no, God, that was awful. I promise I'll never do that again.
Sorry.
no, we need it in our meetings, okay. Little levity.
All right. So I think I would move that faculty and staff at Dover Sherborn schools be required to receive vaccination against SARS-CoV-2 for those that request and receive an exemption from the school district. They be required to undergo frequent testing for COVID. And that furthermore, that the list of approved exceptions be subject to review by the boards of health. Does that fit your last part, Steve?
I'm sorry, I was distracted for a second.
All right, and I didn't write it down, so now I got to try again.
So I think just for language on the exemptions, I think our goal is not to review any individual personnel issue, right, but rather the approach the district has taken in regards to the exemption policies and procedures. Not that so-and-so has an exemption, these are the features. I don't expect for us to weigh in on individual data, but, you know, I'm left-handed, is that a legitimate exemption? You know, as a category, I think would be in our purview. Does that sound right?
Yeah, that makes sense.
And what about having our combined boards of health review the plan for testing for people who are exempt?
Probably makes sense.
Yeah.
Yeah.
Okay, so let me, I pulled up a blank document here so we can try to write something.
I was wondering what was happening.
Does that sound reasonable? Because I won't be able to say what I said again, and maybe we can just get it down and agree on it. Okay. So faculty and
we would
staff.
be able to know what you said from the recording of this meeting. And
right,
it did sound reasonable to me, but if you would like to try writing.
I feel like if it's written, then we'll know what we're all voting on, and we can just send it to Ellen as well. Does that make sense?
Sure.
Yes.
All right, so faculty, staff in Dover, Sherborn regional schools are required to be vaccinated against, now I gotta get my capitalization right, SARS-CoV-2. There should be a process in place to request exemption, and those that receive exemption are required to undergo frequent testing for COVID-19. And then we want to say the specific policies on exemptions and testing developed by the district should be reviewed by the joint boards of health. are subject to review. What do you want to say?
Will be reviewed by.
I love writing boards of health. It's not as good as attorneys general, but it's close.
Yeah.
How do we feel about that text?
I would say will be reviewed jointly by the.
I'm hoping there aren't any English teachers on here right now judging me.
I was
Or
just
typing
like, is
teachers
it
for that
should
matter.
or shall? I was like,
I think
was
it's
like,
actually shall. We said
Shall would
will.
be, but I liked Steve's will because it
Yeah.
makes it that we are offering to do that, but shall is the legal, it's required
Yeah.
term.
I like shall. And instead of there should be a process, there shall. Yeah.
Then in the spirit of shalls everywhere, those that receive exemption shall be required.
Yeah.
Looks good to me.
All right. I will move that we
Yes.
adopt this unless there's further comment.
So moved.
Second,
Any other comments from the Sherborn Board of Health? And then we'll vote, and then Dover will have an opportunity. All right, so Daryl Beardsley, aye.
Matt Beavers, aye.
Lisa, I.
Rebecca Honeywell, aye.
Matt Vitale, aye.
Okay. And Dover?
I move that we adopt the regulation that just adopted by Sherborn.
Second.
Aye. Kay Peterson, aye.
Aye, Stephen Kruskow, aye.
It's passed.
And I see a late breaking hand by Simon Body.
And are you able to unmute your, there you go.
My apologies for butting in so late. You've written COVID-19 implying an antigen test. I think we would want to say a PCR-based test, in which case it should be SARS-CoV-2.
So I think yes, ideally we would have a PCR test. Functionally, it may be more likely we're getting an antigen test if we want frequent testing. We've looked at the performance of the Binax now, and it's approaching that of PCR currently. And that is likely to be the more accessible test. So I think while PCR would be ideal frequently, it's probably not likely we're going to get PCR multiple times per week.
Okay.
We may be able
Thank
to get PCR once a week.
Yeah.
Because it's now there's pooled testing available using PCR once a week, but that's the extent of it right now. I would hate to see us locked into a particular type of testing
Yeah,
by our regulation.
I agree. We shouldn't be prescriptive. We should be performance-based. That makes sense, Kate.
And so
This
it sounds
one
like
of the-
there's a distinction in the wording. So having it as frequent testing for COVID-19, will that cover all the types of tests, mix of tests that the school administration may want to pursue?
I believe so.
I do too.
Okay, all right.
Can I just make a point that this is what the difference in sensitivity between the antigen test and the PCR test is part of the argument for really frequent antigen testing. You know, it's the sensitivity goes up dramatically if it's used more frequently. Anyway, but we'll have to see what's feasible.
All right. So I think it sounds like we've got a motion, we've got it passed, and
All right, and does anyone either on the boards or in the audience have any questions? or comments before we adjourn? Okay. and
I
this-
would just request the testing be put on our next agenda because I think it
Perfect.
just is more efficient to have it all addressed together or as soon as possible.
Ellen, can we include that on the agenda for the next Sherborn meeting?
I don't think Ellen's here.
Yeah,
Okay.
Ellen's not here, Matt.
Ah, perfect.
That's
Fair
why I
enough.
wanted to write down the motion.
I'm here.
Oh, there you are. I didn't see you,
I was
Ellen.
muted. I
I'll
was
still send you the
muted.
motion.
Yes, thank you.
And if we can include testing on the agenda for the next Sherborn meeting.
Yes, as a bullet under the COVID-19 update.
Yep,
Yes.
that sounds right.
Yep, okay, we'll do.
Thank you.
All right. Do we want to
All
close
right.
out?
So is the Sherborn Board of Health in agreement that we shall adjourn?
Yes.
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 Okay, and yes for me. And Dover?
Yes.
Yes.
Have a good night, everybody.
Good night, all.
All right,
Right.
Thank you.
thanks all.